Why don't we get started? It's my pleasure to welcome you to the SAGES Symposium on Healthcare Reform. We have a very distinguished panel, and I'd like to introduce people. This has been designed with a fair amount of slack at the end for questions and answers, because I suspect that people have, if they don't have questions, they probably have strong opinions about the subject and would like to have a little bit of a town hall format at the end. I'm David Ratner. I have no disclosures that are relevant to this talk. My co-host is Dr. David Hoyt, who is the Executive Director of the American College of Surgeons, and we will try to keep things on track and so forth. David, do you want to make any comments before we get started?
Yeah, thank you very much. Good morning, everybody, and it's really exciting for me to be here with you. I don't think there's anything that's perhaps more important that's going on at a national level than the healthcare reform and how it affects us as surgeons. And I hope one of the things that will come out this morning is just how well prepared we are as surgeons to participate in this discussion, both by virtue of our expertise, but also because we're really bringing something to the table in terms of our definition of quality programs. So I look forward to the discussion this morning and the panel discussion.
Well, as many of you know, a lot of the healthcare reform, I won't say started, but came to a head in Massachusetts when Massachusetts enacted universal healthcare coverage. And I'm very pleased today that we were able to have Tim Murphy come and speak to us. Mr. Murphy is currently the president of Beacon Health Consulting, but for our purposes today, he was the Secretary of Health and Human Services in the Romney administration in Massachusetts when the landmark legislation was passed. And Dr. Warshaw and Dr. Hutter all actually live in this system. You can see we're still here and surviving. And I thought I would have Tim talk about the lessons learned from the healthcare reform in Massachusetts. Tim, again, thank you very much for coming down here.
Well, thank you, and good morning, everyone. It's a pleasure to be here. What I want to do very briefly, I don't know how you can do this briefly, 15 minutes to talk about Massachusetts healthcare reform, but let me attempt it. Why did we do healthcare reform in Massachusetts? The first couple bullets here apply to every state in this country. You have double-digit inflation. We had a lot of people who were uninsured. Small businesses were getting really challenged to purchase health insurance on behalf of their folks. Those last couple bullets, though, are the reasons why the bill got done. We had a money problem in Massachusetts. Our what's called an 1115 waiver for the Medicaid program in Massachusetts was found to be out of compliance with the federal rules, and we were going to lose a lot of money. So one of the things that's interesting about Massachusetts is while there might be, this kind of sense of there was a lot of altruistic reasons why we were looking to kind of get everybody covered, the catalytic reason why we got the political will to get it done is we were about to lose $385 million from the federal government, which was coursing already through our hospital system in Massachusetts. And no governor, no Senate president, no Speaker of the House, an elected official wants to kind of, sit over a situation where they lost all that money, and then how are they going to make it up? Are they going to take it from schools? Are they going to have to raise taxes? And so that was really an impetus for us to get going. I'm sorry, I don't have any disclosures. Let's talk about uninsured in Massachusetts at the time that we did the bill. A state of about 6.2 million people. And we were a pretty fortunate state. We did not have, as a percentage, a ton of folks that were uninsured in Massachusetts. If you contrast it with a state like Texas, where rates run from anywhere from 20 to 25% of the people don't have health insurance. In Massachusetts, depending upon what analysis you looked at, it was somewhere between 8 and 12% didn't have insurance. One of the insights that we made, though, was when we looked at the people in Massachusetts who didn't have insurance was to understand why didn't they have it. There's a perception that the uninsured must be very, very poor people. Well, in Massachusetts, very poor people had really good health insurance. They had health insurance that was better than a lot of people who work for small businesses. It's called Medicaid. So what you had to really do is to pierce through to say who didn't have health insurance. On this slide here, one of the things that drove the policies in Massachusetts was this kind of segmentation. What we found was 20% of the uninsured in the state were actually eligible for the Medicaid program in Massachusetts. They just weren't enrolled in the program. That shouldn't come as a great surprise across the country. On average, only 7 out of 10 people who are eligible for the Medicaid program are actually enrolled in the program today. It's just each state kind of enrolls people differently. A lot of folks don't sign up. People move around. They're hard to kind of redetermine back on the plan. And that's something that we really wanted to focus on in Massachusetts. So we knew we could eliminate, 1/5 of the uninsured in the state if we just got people enrolled in the program that they were eligible for. The next group is the people who earn more than 300% of the federal poverty level. Those individuals, or that's a single person making about $30,000 a year. Our view is if you're a single person making $30,000 a year, you have the financial wherewithal to actually purchase health insurance, but many people weren't. They were the so-called young invincibles, people under 30, 40 years old who felt that, I'm in good health, why would I go buy health insurance? But the real keen insight that we found out of Massachusetts is we had just overregulated insurance markets. We had made the purchase of health insurance for people who weren't tethered to an employer very, very expensive in the state. And so we needed to go and deregulate our insurance markets to actually make this opportunity for 40% of the uninsured who actually had economic resources, that it was economically reasonable. And so we did a lot of that in part of the plan. And then finally, you have this group of folks. They're not eligible for Medicaid. They don't earn more than 300% of the federal poverty level, and their employer doesn't make them an offer of health insurance. And for those individuals, about 40% of the uninsured, what we found is that it would be really challenging for them to buy health insurance. So we wanted to devise a way that we could actually take resources at the state level, coupled with their own private resources to help them buy private health insurance. So the Massachusetts law was predicated upon getting people access to health insurance. It wasn't predicated upon how we control cost. It wasn't predicated upon how we get to the quality. I'm going to speak to that in a few moments. The way that we did it, though, is we protected the federal funding that I spoke about earlier. For those individuals that were these tweeners between Medicaid and people earning more than 300% of the federal poverty level, we determined that we were going to take subsidies that were going to hospitals, and we were going to reposition those subsidies and give them directly to individuals to allow them to buy private health insurance. We did major insurance market reforms. As an example, we combined the small group market, which is for small employers, and the non-group market, those are for individuals. In Massachusetts, the individual market in Massachusetts was a dysfunctional group market. It had been overly regulated by the legislature, and it was just too expensive for people to buy in it unless you were sick or you were older and thought you could become sick. Everybody else opted out. So we combined those markets and did a number of other things, creating plans as an example for younger folks that were more kind of in line with what their needs were. And then finally, you hear all these discussions about an exchange. So we were the first state that came up with an exchange. They called it a connector in Massachusetts. And that was a way in which we were going to bring buyers and sellers together and do that in a more efficient way. So how have we done? How have we done? It's basically going on 5 years now since we started the health plan. So if there was about 500,000 people who were uninsured in the state, as of June 2010, 402,000 people have got insurance. So over 75% of the uninsured in Massachusetts at the time of the bill that was passed now have insurance. That equates to 98% of the population is now fully insured in Massachusetts. And any economist would tell you in an employer-based system at 98%, that means everybody has insurance. It's just sometimes people drop insurance as they move between employers. So from an access perspective, I don't think that you can make any argument that Massachusetts health plan, how it was structured and designed, has actually been very, very good. Let me just talk about the ways in which we got people insurance, and this is through this exchange or connector, and it's important to spend some time on this because this will directly affect, if the federal law goes into effect, how people are actually starting to access and purchase health insurance and therefore how they have access to the services that you offer to them. The exchange in Massachusetts did two things. One, it administered the subsidy program, and two, it served as a clearinghouse for people who weren't getting a subsidy from the state, just connecting buyers and sellers. Think of like a Travelocity or a Priceline. You kind of go up, you buy on your own. On this Commonwealth Care program, the subsidy program, these are just some of the aspects of the program design. But what the important thing for folks to know is this: it's an insurance model. Some government money, some private money, you buy private health insurance. What is it about these folks? What have we found out here? Let me just walk you through some slides really quickly about these new people who got insurance, because there's a big concern. They haven't had insurance, they must be really sick, they're going to show up. So what I've done for you here is to basically show you some slides that are going to compare what's a TANF adult, that's a Medicaid adult person who is not disabled. And then it's the ComCare, which is this new population of people who got a subsidy to buy private health insurance. And then the small group market, that's the existing market where people are buying unsubsidized private health insurance through their employer. The average age of someone in the small group market in Massachusetts is 47 years old. The average age of someone in Medicaid who is an adult is 34 years old. The average age of these newly insured people coming in are 38. So a lot younger than your typical kind of commercial insurance population. If you look over here, you can just see how it spreads on the gender side. It's a lot more male than what you typically see, and that's an important insight. How about how much money they spend? Interestingly, they spend about the same. They spend about the same. So this is the cost of the on a per member per month basis of the claims experience for these new populations. So they spend about the same as someone who is in the TANF Medicaid program or someone who's getting a small group market rate. So in essence, there's this big concern that all of a sudden these folks are really expensive. They're going to roll in and spend tons of money. They really don't. And then this starts to break down the various components where they spend money. So inpatient hospitalization. Interestingly, the TANF adults, the youngest, the 34-year-old average age, spends the most in inpatient services in a hospital. Now that might seem counterintuitive. Why is that the case? You might not be surprised to hear that in the Medicaid program, what is the biggest procedure that's paid for? Maternity. Medicaid favors young women who have children. That's how the program is set up. And so they spend a lot in hospitals because they are having children. Whereas the rest of this population skews a lot more male. And so therefore it has the natural kind of age adjustments. On the pharmacy claim side, as you can see here, they kind of spend in between what the small group market does versus the TANF population. And again, I keep going back to age on this. The younger you are, the less you'll spend on the pharmacy side, the older you are. So 34, 30, 37, 47 years old, that makes sense. Non-medical, non-inpatient medical, about the same amount of money. Emergency room expenditures, this is an important part if you're running a hospital. As you can see here, the TANF population spends $32 a month, PM, on emergency room expenditures. Again, why would that be the case? These are young women, basically, average age in their 20s. Why are they spending the money there? They're using emergency rooms for primary care. Like they don't have access to primary care. They might not go to the local community health center. They might be closed after hours. They go and use emergency rooms considerably. As you can see in the small group market, someone who's got insurance through their employer, they're only using it $13 a month. Now this new group of folks rolling in who have a subsidy, they're using it $24 a month. These are people who haven't had health insurance before. So they haven't had access to primary care doctors. They don't have a medical home, if you will. And so the way in which they have used the healthcare system when they didn't have insurance was to go to the emergency rooms. That's still occurring, and those are things that we're trying to change. Here's a big difference about where people actually use the health services between the newly insured and the folks that have previously had insurance, and it's on the mental health and substance abuse side. So on this slide, very simply, on your left is the inpatient mental health admissions as a percentage of total membership. This is a penetration rate. So the typical penetration rate for an adult in the Medicaid program, non-disabled, is less than 1%. For the small group, it's 0.5%. For these new group of insured folks who have a subsidy, 1.6%. These are massive changes. You take a look on the substance abuse side, you can see the multiple difference here. The point is that a lot of the folks who will be getting subsidies, through the federal reform, who are going to be rolling in, are people who didn't have health insurance before. They're going to be younger, they're going to be male, and they're going to be people who have mental health and substance abuse conditions. And in some ways, it should come as no great surprise. The Medicaid program has always favored women with children, and it has actually disfavored the coverage of mental health benefits, and that goes back to 1965. If you're someone struggling with a substance abuse or mental health problem, it's really hard to hold a job consistently, and so therefore you're unlikely to actually be in an employer-based system. So these are these gentlemen or these men who have been kind of rolling around systems, getting access where they can get access, emergency rooms, public health programs, etc. Now we give them a card, now they have insurance, now they show up, and while their cost in the main might be about the same, they tend to use a lot more mental health and substance abuse services. And this is just demonstrated here on a per member per cost basis. If you take a look at how much they spend on mental health and substance abuse, they're spending $36 a month versus $7 a month in a typical commercial plan. It's a massive change. And I think there's going to be a lot of questions about whether the system is going to be actually available in a number of different states to actually handle that. These are not built out systems. On people who don't get a subsidy, there's a clearinghouse mechanism called an exchange. And again, think about Priceline, think about Travelocity. The idea here was to kind of fundamentally change the way in which people experience the purchase of health insurance. And so the connector simply is basically connecting buyers and sellers. So in Massachusetts, we have a number of different health plans. You have different people who can actually go to these health plans. This connector was supposed to actually be a place in which people could transact to buy health insurance. Unfortunately, it hasn't really worked. Hasn't really worked. And this is going to be a big issue for the federal reform. They've got a lot kind of riding on exchanges actually working. So 4 years later, 5 years later, the connector had an addressable market in Massachusetts where they could legitimately sell to 800,000 people in Massachusetts. That's how big the marketplace was available to them. Today, only 36,000 people buy through the connector 4 years later. Of the 36,000 people who buy, what's kind of interesting about it is this. It's basically 80% of them are individuals. They don't even come through an employer. The connector or the exchange was supposed to be this great vehicle for small businesses to actually get a better deal to buy health insurance for their employees. Small businesses aren't showing up. They're not showing up at all. What you end up here is a bunch of individuals who come in. As you can see, 60% of the people are under the age of 44. And on the benefit level, YAP is a young adult plan. That's kind of more of a stripped down plan. And a bronze plan is one with higher deductibles, if you will, on an actuarial basis than a gold plan. People are buying the cheaper plans. So it's an individual place for people to show up. It's for younger folks to show up, and they buy smaller plans. That's okay. There's nothing wrong with it. But I would say as the person who kind of came up with the idea of an exchange, I'm significantly disappointed. I haven't been, Governor Romney left office in 2007. I don't have anything to do with the administration of this. But I think that this is a big disappointment, and it could be a real harbinger at the federal level about one of the big organizing principles of this law is about people using exchanges to drive value within healthcare through the purchase of insurance. And I've got some real questions about how this was designed and executed in Massachusetts and what the bad lessons will be, if you will, learned by other states on this front. So why hasn't it worked? One is it's a politically appointed board, and I think that always has some challenges in it. In addition, a lot of poorly designed offering for small businesses. The idea of the exchange was this. It was supposed to say to every small business in the Commonwealth of Massachusetts, you should not pick the benefit, the network, the co-pays, the deductibles, anything on behalf of your employees. Let your employees go figure that out for themselves. You cannot expressly know what their healthcare preferences are. All you are as a small employer is someone who actually gives them money to help them buy health insurance. And I say that as someone who employs 500 people. I get to pick all of those things I just went through, but really it's just about money for me. You know, I pay them a wage, I buy them a benefit. So a family plan in Massachusetts and my employees, I give them $10,000. The idea was essentially to voucher them and say, here's $10,000, you go to a properly functioning exchange, you pick an insurance benefit that makes the most sense for you and your family. I don't want to have anything to do with it. And then you can start to have conversations with people about value. Right now, there is no conversation about value because the consumer is not involved at all. There are a lot of entrenched interest. Brokers don't like when you have people going to an exchange. Think about travel agents before Priceline and after Priceline. They don't exist, or they only exist for really complicated things. Brokers, make 4 or 5% on every insurance premium, and so there's a real concern from the broker community and other folks that exchanges will be disruptive to the way in which they make their money, and that's a reality. And I think ultimately, these exchanges across the country are going to fail if employers don't recognize that this is essentially an opportunity to voucher their employees, to let them go to an exchange, and again, let the consumer make a lot of decisions for themselves. Now, everything I've talked to is about health insurance and about access. You all know that that doesn't create value within the system. What creates value in the system is if you have the right access, you have quality, and you have cost, and you get those to come together to create value within a healthcare system. So the question is in Massachusetts, and the question will be in the federal reform law is, are you an optimist or a pessimist? Are you right or wrong to focus on access as the principal organizing, or the organizing principle to actually start to get at the conversation about value, cost, and quality? And basically an optimist will say you absolutely have to do it because if you have a bunch of people who are uninsured, you can never really wrangle down a conversation with providers because, and I can say it as the former Secretary of Health and Human Services in Massachusetts, I had more conversations with CEOs and CFOs of hospital systems, and anytime I would try to talk to them about the value that they're delivering to the Medicaid program, they would come back to me and say, I have all these uninsured in my emergency room, and you're not paying me for them. And it's like, you can't even have a conversation about value because they would always throw up the fact that people don't have insurance and those costs are either being absorbed or socialized. And then there's the pessimist that says, you know what, better access is just another government program. We're just going to pay for it. We're never going to get to it. In Massachusetts, I think the jury is out. We have much better transparency today on healthcare costs and which providers are getting money. That was one of the things that I focused on a lot, like how much does each hospital get? I knew their balance sheet and their P&Ls better than most of the CEOs knew them when we were putting this plan together, because I had to take money from certain hospitals to make this to happen. There are definitely a lot more conversations about cost and quality going on in the Commonwealth. I think it's really been slow, but they're happening. And the healthcare reform law in Massachusetts is not busting the state budget, no matter what kind of anybody on the left or the right says. That's just not the case. It has cost exactly what we said it was going to cost, and it's actually relatively immaterial in terms of the incremental spend versus the rest of the state budget. Then on the negative side, the healthcare costs in Massachusetts continue to rise the way that they're rising before. So we've made no inflection whatsoever on the cost of care. I would say this, there's a lot of folks who say, oh, the cost of care has actually exceeded or gone up more after the law. That is just a flat-out incorrect statement. There's no tangible evidence of quality improvements, and no one is purchasing on cost and quality today. Nobody is still, 5 years later, and that's a real disappointment. And I think that the problem is going to be this. What we're seeing right now in Massachusetts is there's a frustration level, particularly among small businesses, about the cost of health insurance and the cost of health care. And what you have now is essentially a lot of folks focusing on how can therefore government regulate how you conduct your business and how much you get paid. And I think that that's my biggest concern about the federal reform law and what's happening in Massachusetts right now. Over the past year, there has been, in my mind, a lot of attempts of price controls. A lot of bullying of insurance companies. That bullying is now manifesting itself in a new law or a new bill that would actually pierce the insurance premium into the contracts between insurers and providers, and the state would decide whether that was an appropriate rate increase or not. And I think that that's something just to be very careful of and to judge as we move forward. So that's kind of a quick tour de force, if you will, of what happened in Massachusetts. There's a lot more, obviously, to it, but I want to be sensitive to time. I thank you for your attention.